Hello,
Alaikum salam.
Alaikum salam.
can you hear me clearly?
Yes, yes, Sidr, we can hear you. It's very clear.
Okay, okay. And how many people are we expecting we want to start because of time?
I'm not quite sure. Is Najib in here? So maybe Najib can confirm. Let's just give them 3 more minutes, then we start
And then we
9:30.
start. Okay, yeah.
Okay.
So I'm Saddrudeen Ali. I'm a level 5 MBCHB student, and I'll be taking you today through pediatric history taking and general examination. So first of all, before taking any history, there are some prerequisites. So first of all, you need to gather your necessary tools, the clipboard, a pen, a measure, preferably a more, etc. So make sure your clacking tools are ready. Then you ensure you're in a comfortable, child-friendly environment. So maybe an environment that's well lit, has adequate ventilation, maybe toys, if any toys are around, as you can see from this first image, maybe a teddy bear. Just make the child feel that they're in a comfortable environment. Then you have to introduce yourself to both the child and their caregiver or caregivers if they are more than one. So you introduce yourself and you also explain the purpose of the history and examination to the child and the caregiver. So you address any concerns or questions regarding the examination and the history taking process. So it's good to elaborate, how you're going to take the history and how your examination that involves, maybe exposing the patient in some areas. So you address any concerns by the mother or the informant, and then you assure her that everything will be well. And always stand at the right hand side of the patient. It's a golden rule. Whenever you're taking your history, whenever you're doing examinations, unless you're examining maybe from the foot of the bed, the systemic examinations, which we are not going to cover here, but ideally you should always stand at the right hand side of the patient. So let's say we have this bed here and the head is here. Obviously the right hand side will be towards the wall, and you will be now on the patient's left hand side. What will you do? Let me ask Amir. Amir, what will you do in this situation? Let's say you find you may in your ward, and then you find that the bed is at the corner like this. The patient's head is here. Obviously, the right hand side will be towards the wall, and the patient's left side will be towards you. What do you do? And you've been told you have to stand at the right hand side of the patient. Are you going to move the bed? There are no wrong answers, by the way. Just try. Anybody? Kausar is saying, I would like to. No action says no. Yes. No action. Can you maybe give a reason why you will not move the bed? Because you have to stand at the right side of the patient.
What I would do is that okay, the patient is not planted onto that bed, so I'd maybe make him lie with his head on the other side of the bed, like if his head was going towards where the books are placed, ensure that the feet are on that side, and then I might be required to move the pillows to the other side, like to the other end of the bed, and then I make him lie towards the side. At least with that, the right hand side will come to my side. So
Correct. You never move the bed. So if the patient's head was on this pillow, you just tell the patient to put the head now towards this end, towards the end of the bed. So automatically now the patient's right hand side will be on your side. So that's one trick. Good job. Let's continue. So next is after introducing yourself, is taking the biodata. Biodata, you have to take the name of the child. It's normally part of the continuation sheet. The age of the child, the sex of the child, the residence of the child, the name of the informant, and the relationship of the informant to the child. Whether it's the mother, and never always assume that that's the mother. You might find someone who's with the patient, maybe the aunt, the grandmother. Actually, there was a case in the pediatric ward during my rotation. There was a grandmother of 30 years, 30 years old. So you can imagine, people thought that it was the mother, but yet it was the grandmother. Always ask the relationship of the informant to the child. It can be even a neighbor with the child. So you always also indicate the day of admission. And once you're presenting your history to your consultant, ensure you don't say the specific date. Was admitted, let's say today is 16th February. No, you always put it in days, weeks, or months. Was admitted 2 days ago, was admitted 4 weeks ago, was admitted 2.5 months ago. So please make sure, make it easy for the consultant not to do the calculation for you. Always put the date of admission in days, weeks, or months. Next, you go to the presenting complaint or the chief complaint. You just list the main complaint, or if it's mainly the complaints, just and also the duration of the main complaint, from the oldest to the most recent. For example, you can say presenting with a history of cough, then took for 2 days. Presenting with a loose stool for 5 days or 5 weeks. So it's just a short complaint and also the duration. Start with the one that is oldest, the most recent. So majority of the history from your history taking is going to be elaborated in the history of presenting illness. And here you have to be as detailed as you can, because here is where you get most marks when you're tracking your history. Not in the biodata, or not the rest of the history, but it's on the history of presenting illness. So you start by asking the patient, is there any chronic illnesses or major illnesses in the past? So you can start by introducing a HPI by saying, the patient is a non-diabetic since 2020 and is currently on this and this medications, and is he compliant? And is he compliant not? And is compliant to medications and presents now with this and this and this. That way, you want to, don't do history as the normal 30 years. Just be very, right now you're very advanced. I want you to have like an advantage over the rest. So start by introducing if the patient has any chronic illness. For example, you can say sickle cell anemia is a patient with sickle cell anemia, or a patient with cancer or HIV, especially if it's important to the presenting complaint. And maybe you can say and the current medication he is on for that condition. So for example, you can say a non-sickler presenting with sickle cell crisis. And also it's good to say that when was the patient last well? And remember, you don't say the date, you always mention the duration. 3 weeks ago, 2 weeks ago, etc. Never mention the specific anywhere in your history. So you describe the symptoms as they appear, and I know you've all come through this this mnemonic Socrates. So you start with the site, especially if it's pain, but not for all other symptoms. So you can the site, you ask about the onset of the site. For example, if it's let's say headache, you can classify, is it a global headache over the entire head, or is it in the temporal region, or is it an occipital headache? Onset can be insidious or sudden in onset, insidious, and also gradual. Is it something that is sudden, or something that is progressively progressively, over a long period? Character, is it a sharp pain? Is it stabbing pain? Irradiation? You can ask about whether the pain is going anywhere else. For example, pain referred, let's say from the abdomen, the right shoulder, could be something to do with the liver, maybe cholecystitis, something of the sort. And associated symptoms. Is there any fever? Is there any vomiting? Is there any blood vision? What's the associated symptoms? The timing, is it more during the day? Is it more during the night? Is it every 20 minutes? Does it have no specific timing? Is it throughout through the day? And what are the exacerbating factors that make it worse? And what are the relieving factors? So relieving factors does not necessarily mean drugs, but maybe, for example, the mother saying the patient is complaining of fever, but it's relieved by removing clothes from the baby, or by giving bathing the baby in cold water. Could be a relieving factor. So severity, that one you can use the mnemonic first. Yeah. So it means that if you cannot tell a baby, let's say a 3-year-old baby, is in pain. Yes, you can know is in pain, but how are you going to know? You cannot tell the baby or the mother to tell you on a scale of 1 to 10, how does the baby feel? No. You just check on the severity by looking at the feeding. Does it affect the baby's feeding? Does it affect the baby's appetite? Does it affect the sleep? Does it affect maybe playing with others, or any school activity? So you look at the change in feeding, the activity, sleep, and the temperament. Temperament really means the behavior. You notice now the baby is starting to change behavior, is withdrawing from people, something of the sort. Temperament basically means behavioral. And if there was associated weight loss. So once you have finished now expounding on the symptoms very well, because that is the main, if you come to, telling us about a past admission in Mama Ngina Hospital 1 year ago, no. First start by describing the main symptoms as I have said. You start by introducing any chronic illnesses, and if they are on any medication for the same, then you describe your symptoms by using the Socrates. Then you now start talking about now the progression of the disease. You never go to the progression. The lecture will feel very boring. First of all, describe the symptoms. So if the patient is admitted, ask if the patient is admitted to other institutions for the same condition. You mention the hospital. How are they managed? For example, mentioning the drugs. If they were compliant in case of using drugs, and if the condition has improved with treatment, and it should be in chronological order. So I can say, for example, the patient is a non-diabetic who was admitted previously in Mama Lucy Hospital, who is being managed on insulin and is compliant to insulin, and his condition is deteriorating. Something of the sort. So you now mention what the treatment they have received currently in Kenya, or at the time of the current treatment that they are on. It's not good to know, Yani. Just it's good to know the drug. I know you can, right now you're finding that it's brand names. It's not the regular insulin that, maybe Nakeni, Lispro, Aspart. Some drugs, they're not giving you the pharmacological names that the pharmacology. Just try what here. So you mentioned the treatment that they're receiving currently, and if the condition is improving or is it deteriorating, and any drugs that are given, even if it's oxygen. It's also important that oxygen is also, you consider that oxygen is also a drug. So then you ask about risk factors, for example, family history of the disease. If it's history of pneumonia, you can ask about history of any air pollution in the home, history of contact of someone with similar disease, something of the sort. Then for conditions, for relevant conditions, also ask about history of travel to an endemic area. I'm sure you can't use malaria in the wards. It's also good to ask about history of travel to a malaria endemic region or a disease that's endemic in a certain region. Then history of close contact, for example, in TB or other respiratory illnesses that are spread through the respiratory droplets. Then also history of similar presentation at school, at home, or even in kindergarten. So a case we saw in the ward during my rotation, we had a baby who came with tuberculous meningitis. And apparently she got it from someone who had TB in the kindergarten. It's good to ask about history of similar presentation in the patient's surrounding. As you can see, how the HPI is quite detailed. At least you should mention everything from what. But remember, just a quick recap of the HPI. You introduce any chronic illnesses. Then after that, you describe the symptoms using Socrates. Then you start mentioning if there was a previous admission in the hospital, in any hospital, what drugs were given, are they compliant, is the condition deteriorating? Then now you go on the current treatment, the current condition is improving or deteriorating, any drugs including oxygen supplementation, risk factors, for example, family history of disease, history of travel to an endemic area, history of close contact, history of similar presentation at school, at home, or at kindergarten. So for the past medical history, you mentioned the chronic illness. Now you mentioned above, and you remember when you're seeing the HPI. Now you mention, you now expand on the condition. Then you can mention the drugs maybe they're taking for that condition. Are they compliant? You just leave it at that. So it's also good to ask about history of surgeries, past admissions, past trauma. I know you to yourself. Never just it's good to also mention past trauma, for example, fractures, past blood transfusion, or even blood donations, food or drug allergies, and the drugs taken for the chronic illnesses that the patient has had in the past. So for the prenatal or for the antenatal history, it's basically everything, and from the baby's conception until the baby is given, the mother gives birth to the baby. So until when birth comes, that's when we stop eating there. And it's everything when the baby is still in the mother's womb. So first of all, what do we do with the diagnosis? You ask about the diagnosis of pregnancy. Was it rapid urine HCG? The women like urine in it. Was it through an ultrasound? And which clinic would mother go for her ANC visits? And when was the first visit? So the first visit is very important. Ideally, you want how frequently. According to the current standards of WHO and the current standards of I think KNH, ideally a woman should have 8 visits. Sorry for the typing error there. So 8 visits means at least 1 visit a month. So by the time you're in the first trimester, which is 3 months, the first 3 months of pregnancy, ideally you should have 2 visits. Then if you find a lady coming now, in the second trimester, for example, in month 5, she has like 5 previous months ambayo hajakuja clinic even one. And remember, the organs are developing from, I think, week 4 to week 8. They're already developed. The heart, the brain, everything is already developed. And maybe the mother, because she didn't come to the clinic, maybe she missed some information about how to handle the pregnancy. So remember, by week 8, everything, or week 13, there everything is the organs have already formed. Now the baby is just increasing in size. You know, so you can imagine not having the 8th visit. At least now minimum should be at least 4 or 5, but ideally the visits should be 8. So starting, let me you have diagnosis of pregnancy, which clinic was the mother on follow-up, when was the first visit? It's very important, and how frequently did they go? Were there any supplements taken? Normally they take something called IFAS, iron and folic acid supplementation. And were there any vaccines given? Ideally, she should also have a. Was there any screening of diseases? They call it triple serology. They check for HIV, they check for hepatitis, they check for syphilis. Was it done? And what were the results? Was it triple serology? Don't mention triple serology just to sound fancy, but at least found. You know, it can be triple serology for many diseases. Let's say triple serology was done, HIV negative, syphilis negative, hepatitis B negative. Other than saying triple serology negative, the consultant would know what diseases you're talking about. It's good to mention. And what is the HIV of the mother? Because we need to check on risk of mother to child transmission. And was there any complications, any illnesses, any infections during pregnancy that could have affected the child? For example, any history of UTIs, any history of maternal fevers, and if there was any, what were the drugs that were given? Additionally, you should also check the other narcotic drugs, and such as alcohol, tobacco, and narcotics like cocaine, heroin during pregnancy. So basically, that's the NC portion of the history. So the history of infections is quite relevant because, for example, if you have certain infections like syphilis, it might affect the child, leading to maybe cataracts, etc. If you have HIV, there is a risk of transmission of HIV to the baby. I think you continue. So for the birth history now, ask about the place of birth. Was it in a home birth? Was it at the hospital? Was it at a clinic? And if it's a hospital or clinic, the name of the institution. The age of the mother when giving birth. It's important because there's some conditions that are associated with a very low maternal age and a very high maternal age. Very low maternal age will, because of the underdeveloped, the mother's pelvic organs are not ready to, they're not ready to handle the pregnancy. You might find some complications. Let's say cephalopelvic proportion or heavy bleeding, etc. Maybe for an older maternal age, for example, past 35, is a high risk of chromosomal abnormalities like Down syndrome, etc. But the age of the mother is important when she was giving birth. And was the pregnancy at term? We'll talk about it in the next slide. Was it preterm or was it postpartum? Basically, you're asking about the gestational age of the baby. And was the labor prolonged? Prolonged labor, I think it's after around 2 hours for a woman who has given birth before. has a history of a previous pregnancy, or for a new mother, maybe prolonged more than 3 hours. We consider it prolonged. If it's prolonged, it has very high risk. It's very risky for the baby. Remember, if you're not coming out of the mother's womb quickly, you're at risk of hypoxia, etc. That can lead to complications such as cerebral palsy in the future. So you also ask about the type of birth. Was it a vaginal or a C-section? If it was a C-section, was it an elective? Where the mother was booked prior and she knew that she was going to have a C-section, or was it an emergency? Was there anesthesia that was used? Was it a general anesthesia where she was put to sleep completely? Or was it a spinal anesthesia where she was just paralyzed from maybe the abdomen downwards? And if it was an emergency, kindly indicate the reason why. And if it was a vaginal delivery, was it breached? Breached meaning the legs coming first? Or was it a vertex delivery, meaning the head was then, or the normal delivery is called SVD, spontaneous vertex delivery? Was it the head that was coming first? Was there suction required? Suction means, the mother is pushing, but she's unable to get the baby out. So they put some vacuum cups, or they take some tongs or prongs, they kind of extract the baby from the mother's womb. Was there any suction or assistance required? And was it an induced vaginal delivery? So for example, if a mother comes post-term, she was supposed to, let's say, give birth 2 weeks ago, and she's not having any signs of labor, she's not contracting, the cervix is dilated, but the baby is not coming out. Normally they give her induction by giving her oxytocin, so that to stimulate the uterine muscles to contract and push the baby out. Was it induced in the case of vaginal delivery? And all this information, I know even the most perfect mother cannot know everything. That's why it's very important, especially if the baby is under 5 years in Kenyatta. The mothers always have a booklet with them. Good to check the booklet. Everything will be in the booklet. So birth history, check the booklet before even, just have a rough overview of the booklet before going to the mother. Because the mother might forget. Still on the birth history, what was the birth weight? What was the first cry? Was it immediate? Did the baby just cry upon birth? That's a very good sign. The baby cries upon birth. If it's delayed, that's a worrying sign. No, it's a question. This baby probably is not okay. And that's why we do the APGAR scoring. I'll just introduce it, but you just say it's immediate or delayed. So for the complications, were there any complications to the mother or child during pregnancy? Was there any prolonged labor? Was there any obstructive labor? Was there any trauma like that, for example? And how long would they stay in the hospital? Ideally, they should stay for maybe 1 day or 3 days at most, then they should be discharged. If you find that they stayed at the hospital for 1 week plus or 2 weeks, what's the mother doing there? Probably there was a complication, and the hospital was trying to address it. So this is just the APGAR. It's not a must. The mother cannot know anything like APGAR. That's why for you just ask about first cry. Is it immediate or delayed? So basically, they just check for it's just the mnemonic is just from the name. They check for activity, they check for pulse, they check for grimace, appearance, and respiration. For activity, they just check for the muscle tone. For example, if there's no tone, then you give 0 points, and if the limbs are flexed and the baby is moving the hands, 1 point. And if the limbs are flexed without movement, it's 1 point. And if there is active movement of the joints, tone basically it's checking the joints, not the muscle, it's just checking the joints. Are the joints moving? You give 2 points. For the pulse, ideally you want pulse greater than 100 beats per minute, you give 2 points. If it's 100, less than 100, you give 1 point. If there's no pulse, you give 0 points. For the grimace or the reflex irritability, when you try to, if the baby is floppy means when you try to grab the baby by the armpits, the baby just slides past the armpits. The baby is floppy. And if you try to stimulate them, that's floppy is 0, completely 0. Then if the baby you try to if the baby is floppy, then you try to stimulate and there's minimal response to stimulation, you give 1 point. And if there's active response to stimulation, you give 2 points. For the appearance, if the baby is fully pink, which is very hard to find in a baby, is 2 points. Nobody is born like fully pink most of the time. And if the baby has a pink body, maybe blue fingers or cyanotic or blue extremities, you give 1 point. Most babies, actually 8% of the babies who are normal will fall under 1 point. It's hard to find a fully pink baby. Then if the baby's appearance is fully pale and blue, that already gives 0 points. If there is respiration, you listen for the breath sounds, look if there's any chest rise. If it's absent, 0 points. If it's slow breathing and irregular, you give 1 point. And if the baby vigorously cries, which is very good for pediatricians to see, or for the birth attendants, it's a good sign. It means that's adequate, because crying means the baby is breathing. So basically, it's just up the score. It's not much you cram all this. Just ask in your history, was that the first one, was that medium or what? So for the birth weight, we said we have to also mention the birth weight, remember? And also the gestational age. So let's go to the birth weight. So a baby less than 2.5 kg going this side, this end, is always classified as a low birth weight. Less than 1.5 kilos is very low birth weight. Less than 1 kilo is an extremely low birth weight. You can ignore these two, but most importantly, just know any baby born less than 2.5 kg is a low birth weight infant. Also, we can have an infant large for gestational age. For example, if an infant born 5 kg. So for those infants, we classify large for gestational age. People say above 4 kg, but mostly go with above 4.5 kg. And we find large infants, especially in infants with diabetic mothers. Uncontrolled diabetes will tend to make infants grow bigger and bigger in the mother. So remember, low birth weight, 2.5, and large for gestational age, 4.5. Ideally, the range is about 2 kgs for a normal baby, from 2.5 to 4.5. But ideally, they should be around 2.5 to 4. So for the gestational age, an infant is a post-term, amepita wakati wake wa kuzaliwa, if it's greater than 42 weeks. And a full-term infant it's between 37 completed weeks. Remember, it's 37 weeks, which means week 37 has completed 7 days of that week. And up to 42 weeks, that's a full-term infant. Then for preterm infant is anything less than 37 weeks. Don't ignore the green thing that's late preterm, just ignore it. Just know any infant, let's say is 37 weeks, 6 days old, will be classified as a preterm infant. Just know that. But if it's 37 plus the completed weeks, meaning the 7th day is completed, that's a full-term infant. So remember, anyone who has not completed 37 weeks, even if it's 6 days after that, out of 7 days, is considered a preterm infant. Post-term, anything 42 weeks and 1 day is considered post-term. So 37 to 42 is ideally the full-term infant. So post-term infants are the ones, generally you want to induce pregnancy, because they stay there for long, some complications might happen. So you induce by giving maybe oxytocin, or you can do a cesarean section. But for the preterm infants, we want to avoid labor. So we tend to give the tocolytic drugs that prevent labor. So it's not necessary you cram that, but preterm, we don't want a baby born preterm because it's a high cause of morbidity and mortality. Because the body is not yet fully developed, the respiratory system is not fully developed, the cardiovascular system, the PDAs is very open. That's why we avoid labor. We give the mother some drugs if she shows signs of labor in this period, just to avoid the baby coming out preterm. So ideally, it's between 37 and 40 weeks for a normal baby. So for the nutritional history, it's the nutritional history, because the first time a baby comes, we don't care about nutrition, we care about baby has to feed within the first. If they don't breastfeed, they will be exposed to neonatal hypertension. It's very difficult. So we need that first maybe to get it on time so that the neurons are, it's in an active state. That's why the nutritional history is for the immunization history that we want. So the first breastfeeding should be within 30 minutes, and the duration of exclusive breastfeeding, how long Do you think a baby should be breastfed only breast milk and nothing else? Not water, not food? Mm-hmm. Kausar, how long do you think? 6 months. Yeah, 6 months after. Correct. So 6 months, it will not even giving any water, not even a sip of water. The breast milk can cover all the nutritional needs for the baby for the first 6 months. So the age of, people say the age of weaning. No, that's not right. The age of complementary. If you compliment someone, unamwongezea mazuri ya mazuri yake, si ndio? But weaning actually is the period where you stop the breast milk completely. Ideally, maybe after 2 years. But complementary feeding now, 6 months, 6 complete months, now the 7th month is when we introduce the complementary feeding. At 6 months, 6 completed months. So maybe let's say 6 months, it's the fact. So tomorrow is day one of the 7th month is when now we start complementary feeding. Ideally, it should be, you also check on the type of food, the balanced diet in about there's some, I think, 7 food groups that the baby should take. They should take the things that has I think carrot-like substances like pumpkins, carrots, etc. They should have milk as a one food group. They should have meat. They should have eggs, skuma wiki or yani vegetables, and other fruits. Ideally, they should have at least 4 food groups, different varieties, and it should be a balanced diet. You can ask how the food was being prepared, especially if you find a maybe 2-year-old coming to the world with diarrhea you're concerned about, sanitation or how the food was being prepared. If the child is older, what do they eat now? Ask what you can ask also mother eats if they are the parent. For example, any baby who's breastfeeding, you always check the diet from the mother and the baby. Always, never forget. Because what the mother eats is what the baby gets. And you have to always, this is a high yield. You always have to do a 4-hour dietary record in any patient, any pediatric patient you come across. 24-hour means what? You will be taking history maybe around 7 a.m. or 8 a.m. during your examination. And so you have to go 4 hours. You say, yesterday breakfast, this is what she had. He had lunch, this is what they had. Maybe around 4 p.m. they had a snack of this and this. Dinner they had this. And it's also to include breast milk is also part of the diet. Then you come now to today morning, this is what they ate. Then after finishing, you have to put in is it 1 cup? If you estimate, is it 3 spoons per feeding, per every meal? And what's the quality? Quality means check at least they should eat 4 different food groups that are part of the balanced diet. So you can see here, I think this is the carrot and those vegetables or fruits. Here we have, here, I don't know what's this. We have meat, we have milk, etc. Something we have at least 4 different food groups. So the quantity, quality, and the frequency. Frequency means how many were they feeding? Were they having 3 meals? Were they having 2 meals? Were they just having? And also ask about the general appetite of the baby. That's why it's very important to take a good nutritional history. And here is where many people lose marks. And remember, age of complementary feeding should be after 6 completed months. Then age of weaning. Weaning means you're getting off the breast. People confuse weaning by like the complementary feeding. Complementary feeding just is 6 completed months. Weaning means the duration when the patient is weaning or the child is weaning off the breast, leaving the breast. So ideally, you should breastfeed also for up to 2 years. So nutritional history, that one you cannot get it from the mother, and the mother knows. So for the birth weight and birth history, remember to always check the booklet. So coming to the immunization history, you ask about which immunizations have been given so far. Let's say the baby is at 18 months. You expect them, or under 5 years, or maybe 3 years, you expect the baby to have received all the immunizations. And the mothers can be, can be very forgetful about this. That's why it's always good. These are tricky kind of. When the immunizations were given, are they up to date? If they were not given, give the reason for not receiving the immunization. And you familiarize yourself with the, after this lecture, you familiarize yourself with the immunization schedule in Kenya. You have to know it by heart. So for the immunizations, it's good to check the booklet and check the reason for not giving the immunization. In our pediatric ward, we had a baby in 3B who had lots of seizures. They were wondering what's causing the seizures. And the baby was quite normal at birth, no problem, no complication. 3-4 months down the line, baby started presenting with seizures. Upon it, people, they did lots of tests and everything. They didn't find anything. They did a head MRI. Nothing was found. But they realized that the cause of the seizures was actually the immunization with the DPT vaccine, your diphtheria, pertussis, tetanus. And it's normally the pertussis, the whooping cough, pertussis. It's the vaccination that portion of the vaccine, the pertussis toxin of the antigen, that causes a very severe reaction in most babies. And that's why you find that some babies, they're not vaccinated anymore. Unapata, they miss the subsequent doses because of the high risk of seizures this pertussis antigen causes. So it's also good to check them. And the reason, you can say maybe because of a severe reaction to previous vaccinations, or maybe the mother was not in the country, or the mother was in a very remote area, they missed, etc. So this is we want to go through it. And this is the immunization schedule. You'll find the slides. I think a class rep or someone who is in charge of this session will send you this this table of the immunization schedule in Kenya. This is according to the latest guidelines last year, 2023. So it has the age of the child, the vaccine, the dose, then dosage, just ignore it, the route. It's good to at least know. So let me just, BCG is given at birth, and the oral polio vaccine is given at birth. Then we have also OPV, which is oral polio, again at 6 weeks. We have the DPT. And DPT is normally given with hepatitis B and the Haemophilus influenza vaccine. It's a pentavalent vaccine. Ukisikia to the pentavalent vaccine, just know it's Penta 5. We have the diphtheria, we have the pertussis, we have the tetanus, then you have the hepatitis B. It can come as an MCQ, you never know. Maybe when I get for hepatitis A. No, we always vaccinate for hepatitis B. Even in hospital, I think students are being told to get in the Hep B vaccination. We also have the Haemophilus influenza type B. And we have also the pneumococcal virus that causes, it can cause pneumonia and also meningitis. And we also have a rotavirus that's given. So at 2 weeks, at 6 weeks, we have how many vaccines? We have 1, 2, 3, 4. We have 4 vaccines, and 1 is the pentavalent. Don't forget about it. At 10 weeks, the same. We have the oral polio 2. We have the oral polio, the 3rd dose of the oral polio. I think this table is wrong. Then we have DPT, we have hepatitis B and HIB, which is the Haemophilus influenza type B. We have pneumococcal virus, we have rotavirus, 2nd dose of rota and pneumococcal virus. So at 14 weeks, remember, we're going to still have the oral polio. The 4th dose, since birth. We have birth, 6 weeks, 10 weeks, now we have 14 weeks. Then we're going to have the pentavalent, then you have the pneumococcal, we still have the rota, but now the injectable polio virus comes at week 14. So the injectable does not come at birth, does not come at 6 weeks, does not come at 10 weeks, comes at 14 weeks. Just key to note. That's why I decided to go through the table. At 6 months, you're just given vitamin A, which is very important. You have to be given vitamin A. Then you're given the measles rubella. And it's not MMR vaccine. It is not measles, mumps, rubella. In Kenya, we use measles, rubella. We don't vaccinate mumps. Key to note. So at the same 6 months, for in high-risk counties, which are 4 counties, I think it's Baringo, the high-risk counties, Kisumu, where malaria is quite common. At 6 months, apart from the vitamin A and the measles rubella, they're given the malaria vaccine. At 7 months, they're also given the malaria vaccine. Not for everyone. This is in high-risk counties. Then we have at 9 months, remember it's the measles rubella. So for here, at 6 months, I know tulikuwa tumezoea measles rubella at 9 months, at 8 months. But now for these 6 months, for people who are for people who are listening, this is only in an outbreak situation. It's when we vaccinate all children for measles rubella at 6 months, but it's not routinely done. We routinely do it at 9 months and at 8 months. So at 6 and 7 months, basically it's just the vitamin A and and malaria. Measles is only during outbreak and emergency. Why do we give vitamin A at 6 months? Because when you come to 6 months, that's why we need now to introduce the complementary feeding, especially the things high in vitamin A, the beta carotene. We have the carrots, we have the pumpkins, we have the pawpaws, anything that looks like carrot, those fruits and vegetables that look like carrot. Because at 6 months now, the vitamin A stores are starting to dwindle in breast milk. They're starting to, the levels are decreasing. That's why we need to give an 100,000 unit shot vitamin A at 6 months. So at 7 months, remember, it's still the malaria in high-risk counties. 9 months is now we give the measles rubella the first dose. Then we can give yellow fever in high-risk counties. Then you can also now give the malaria, which is the third dose of malaria in high-risk counties. So at 12 months, we just give vitamin A, and it's now 200,000 units because the baby is growing. At 18 months, remember tulisema measles is at 9 months and 18 months. Now it's the second dose of measles. We still give vitamin A. And then at 24 months, at 2 years, when the baby is now getting off the breast, you can give malaria, but just ignore this malaria part. Then for all 10-year-old girls, class 4 girls, maybe I think in 8 or 4, I don't know if nowadays all class 4 girls are at least girls 1 year old are vaccinated for their hepatitis, human papilloma virus, prevent cervical cancer. And then they can extend it to 14-year-old girls. Basically primary. Then at then 6 months after the first HPV vaccine, a second HPV is given. So just a quick summary. Birth is just BCG and oral polio. At 6 weeks, the pentavalent oral polio again, the PCV, the pneumococcal vaccine, and the rotavirus. Same during 10 weeks. At 14 weeks, it's the same, just that we add an injectable polio virus. 6 months, we have to give vitamin A. Measles may be in outbreak, but just ignore that information. Give vitamin A, and the malaria, just ignore about it. Vitamin A at 6 months is important. That one don't forget. 6, 7 months, you can give malaria. 9 months, you can also give malaria. 9 months, the first measles, in case there was no outbreak before, then yellow fever in high risk counties also. But it's not routinely done in Nairobi because we don't have an outbreak of yellow fever. 12 months of age, remember, vitamin A always come in pairs of 6, 6, 6, 6 until you finish like 5 years. So at 6 months, you'll give vitamin A. 12 months, you'll give vitamin A. 18 months, you're going to give vitamin A. 24 months, vitamin A. 9 months or 60 months, while the baby is 5 years, you always give vitamin A. So you can see at 18 months, you also have vitamin A.
Saddru,
Can you hear me?
yes.
Yes.
I don't know if it's my end, but your voice is reducing as it goes sometimes. So I don't know.
Okay. Okay. Can you hear me now?
Yes,
Can you
no,
hear
I
me?
can hear you. Yeah, I can hear you, but there's times that's where you just break off and then come back, and then you come back again.
Oh, but sorry. Am I audible to everyone? I don't know. Anyone just type in the comments. Sophia, I'm audible.
Okay, I think it's my end then, don't worry.
But if I keep on breaking, just tell me.
Okay,
But I'm
sure.
almost done with this thing. Just maybe a few minutes. For vitamin A, just do it every time. 6 months until you reach 5 years. Every 6 months. So 18 months, don't forget. At 9 months, sorry, at 9 months, give them measles, first measles. In case there's no outbreak, you give them malaria. And the yellow fever in high-risk counties. So at 12 months, just know, okay, scale to 12. Is it divisible by 6? Yeah, always vitamin A. 18 months, vitamin A. And it's only the first vitamin A dose that we give 100,000 units, but the rest, up to 5 years, is 100. So the second dose of measles at 18 months, vitamin A again. 24 months, you can give malaria. So remember, malaria, it's at 7 months, 9 months, then 2 years. So malaria at 7 months, also at 6 months, sorry. So 6, 7, 9, and at 2 years. So NHPV, give all 10-year-old girls. Then the second, 6 months after the first dose. I think I made it easy for you. You can go through it later. So you've done the birth history, you've done the nutrition history, you've done the immunization history. What's next? The baby has to grow and develop, right? So for the growth, just ask about the current height and the current weight. For the current height and weight, it's kind of, it can be very difficult to get it, especially if you're in exam situation. We clocked, and the machines there were very, I think it's only one in the whole of 3B that can do that. And it's normally not available for everyone. So the trick here is to check the booklet, especially if the baby is under 5, they will always have the booklet. If the baby is past 5 years old and above, just ask the mother, rely on the mother's information. Okay, you can tell you the current height and the weight. This is very important, to know how the baby is progressing. And the booklet will give you a lot of information about the baby's growth and development. So current height, current weight, that's for growth. For the development, you can check progressively. At 6 weeks, is 6 weeks smiles. Just say 6 for smiling. So for the 4 months, it's the head that you should hold up the head alone at 4 months. Or you can say a forehead, so that you cannot forget about it. 4 months, the forehead has to go. Head holding up. At 7 months, the baby should, when you put the baby in a sitting position, the baby is not rising to sit. You just put the baby physically, you as the parent or as the clinician, or when you're taking the history, the baby should sit supported and should babble. Babble means just few syllables. Ba, ka, nya. Those the letter and the syllable, maybe, and a sound. But cannot say baba or mama. Babbling is different. Babbling say nya, ba, that's something like that. But it's not one word. It's something that does not make sense to you, but the baby is trying to say something. Babbling. And so 7 months, sits unsupported and babbling. At 10 months, the baby should start crawling around the floor, should be able to rise and stand and just support themselves maybe on a wall. And at 10, let's say 12 months, they should be able to say one word. So 1 year, 1 word. 2 years, 2 words. 3 years, 3 words or sentences. So for 13 months, the baby should be able to walk unsupported. So let's just quickly recap. 6 weeks, smile. 4 months, head support. 7 months, sitting unsupported and babbling. This is a very quick way of just analyzing the growth and development history. This is the way I find it easy. Sit supported, unsupported, and babbling. 10 months, they're not now sitting, they want to stand. So they crawl fast, then they stand, holding on to walls, and they say one word. 1 word, around 1 year, 1 word. 2 year, 2 words. 3 year, 3 words of sentences. 13 months, 13 months, they should be able to walk unsupported on their own. So this is kind of detailed. You can say the gross motor skills. Gross motor is like the motor. When they started walking, Now, this is for advanced babies, maybe babies over 2 years. You can just ask the mother when they started walking. Fine motor maybe is just the fine touch, and if they can hold objects precisely with their hand. If you put a peanut on can they feed themselves? That's fine motor skill. Can they fold up their eyes? Language skills, when they started talking. Social skills, are they talking well at school with children, etc. Then after all this, you have to make a comment. Is it adequate? Is it delayed? Is it good, or is it regressed? Just give yourself 2 options. Is it delayed? Meaning it doesn't, they have not achieved milestones. Is it adequate, or is it regressed? So these are just examples, but these are too detailed, but you can just go through it at your own time. Just put it there for maybe people who want the, gross motor, fine motor. Yeah. So you go to the family and social history. For the family of the social history, you have to say the birth order of the child. Is it the firstborn in a family of 5? Is it the 5th born, etc.? Are there any chronic illnesses or conditions in the family, in siblings, parents, grandparents, aunts, and uncles? Is there any history of sudden death in the family, or other deaths of unknown causes? Maybe history of sudden death due to maybe cardiac, heart failure. Is there due to diabetes? Was there any kidney disease, etc.? It's also important to list sex, the age, and the health of other siblings. So just draw a small table. How many siblings are there? 3. You just list 1. What's the sex? First one is male, female, male. What's their ages? Just put in your table, just put their ages, and then just put in a section. Are they healthy or not? Tick X, tick X, tick X, and move on. Sorry. How old are the parents? Good to note. You might find that the mother is 20 years and the father is about 70. That's why you might have, or the mother is quite old. It's good to indicate the ages of the parents. And the parents living together. What is their current marital status? Are they married, living together? Or are they married, then living separately? Or are they living together? Or are they divorced, etc.? Because in adolescence, living together and the marital status really affect the psychology and how you deal with the baby or the patient. And what's the occupation of the parents? So continuation, where they live, is it rent or board? Size of the house, living with other persons. Is it a 3-bedroom with 15 people? Especially if maybe the girl, or especially they come with a history of sexual abuse. And mostly sexual abuse, the perpetrator is someone known to the patient. It's not some random stranger. It's someone who patient knows. And who takes care of the child? If you find that maybe a baby who is not walking, who has not attained walking, yani, let's say we said walking is at 13 months. Let's say you find a 10-year-old baby, or a baby who just started walking with fractures of the arm, the forearm, or maybe the back, you wonder. And the baby is not walking, is not. There must be someone who caused this fractures. Maybe something that can lead you to physical abuse. You notice the baby is kind of drawn from the mother, does not want to see the mother around. It's good to tell Yani. Always check the non-verbal cues. Is there any potential of in the house? Any risks? For example, gas cookers, cold. What is the water source and storage? Do they source it from a river? Is it tap water, or do they store it? Especially if you're worried about it. But it's always good to ask this. If the child goes to school, do they go to school, or the child, if he's a 10-year-old child who never went to school? It's good to, it's a red flag. Do they play with other children at school? Do they interact well? And if there is any of the children that they interact with who had similar illness in the kindergarten, maybe the siblings or school. So for the review of systems, basically now you're coming to ask about any systems that might be involved or might be affected because of the disease. You're just ruling them out. So for example, for the mnemonic here is the caged. And remember the growth and development history I didn't mention, and still find it in the booklet. And actually for the growth and development history, if you can't get this thing right, and if you can't cram it or you can't understand it, a good tip is you can, if your patient is under 5 and has the booklet, at the back page of the booklet, I think the last 10 pages, there is always this thing showing the developmental milestones and whether they have been achieved. And if you forget this in your head, just take the booklet. At the back of the booklet, there's normally the chart showing the MCH booklet, the Mother and Child Health booklet. There's always a booklet showing everything, yani everything, every developmental stage, at how many weeks, how many months, etc. But I'm not saying you rely on that, because you might get a booklet. They're not required to read the booklet. So it's good to also understand here, and just find a way where you can understand this. So for the cardio system, you can, so the CVS, you can say about any history of dyspnea, orthopnea, paroxysmal nocturnal dyspnea. For the airway, you can say any history of tachypnea or fast breathing, any history of chest pain, etc. Gastro, nausea, vomiting, diarrhea, history of abdominal pain. ENT, is there any discharge from the ear, nose, and throat, or is there any throat pain? Dermatological, is there any skin abnormality? Skeletal-muscular, is there any scoliosis, kyphosis, or maybe normal gait or movement? Urinary, you're asking about any pain on urination, the color of the urine, is there hematuria or blood in the urine, etc. Neurological, asking about any history of headache, any history of seizures, any history of epilepsy. So the mnemonic here is caged sun. So this is just, I'm not saying you use this, but this is just how you can do your review of systems, just a quick overview. For example, if you're looking at simple, just 3 things and move. Neurological history, a review of systems, sorry, you can check about dizziness, is there any numbness, weakness, headache, seizures, and tremors. You can see gastrointestinal, severe chest pain while walking or claudication, edema. Gastrointestinal, you can ask about abdominal pain, blood in stool, constipation, etc., etc. This is just a rough overview. It doesn't have to, as it said, was this. Just put 3 symptoms where you can ask every system, then click, put an X. Then comes to the summary. Always note that I know if I've talked for a long time, and also you'll talk in your history for such a long time, maybe 10 minutes, but the consultant honestly will use most of the things. They won't hear you. It's good to put a very good summary, and your summary always comes before the general. I know people say, people are confused with the general examination, they say, now it's in summary. If you go to that format, the consultants always like the summary first, and you go to the general examination. Because if you go to the general examination, thinking that the consultant is summary, they'll think that you didn't write. That's how you lose it. So make sure you put a summary. Summary is just the age of the patient, maybe the sex, the rest, just remove the rest. And other important information about the present complaint, the duration, concerns about the illness, including any previous treatment, with full description of the symptoms. Basically, you're just saying the Socrates again, but in a short way. Pertinent, positive, the important positive. Chest pain associated with fever or productive speech, yellow green, and the pertinent negative. However, there was no.
Sadru, people are saying
Yes?
you are breaking.
Am I breaking, or is it a problem because I'm seeing my mic up?
I don't know. Hata
Maybe.
kwa chats, people are saying you are breaking a lot.
But can you hear me, Mustafa? Were you able to hear me?
Yeah, I can hear you right now, but before you were breaking.
Hapo kwa summary tu, si ndio? Ama?
Hapo kwa summary, yeah.
Okay, for the summary, make sure you include the age, sex. I ignore the race, but put the maybe residence or something of the patient. Another important identifying information about the patient. Basically, you're just repeating the biodata. If I break, just tell me so that I can repeat quickly. And then you put maybe the presenting complaint and the duration. I forgot to put that point. and concise chronological account of the illness, including any previous treatment with full description of symptoms, including the pertinent positive and pertinent negatives. Let's take an example. So I can say, for example, I hope there's no one called maybe Hafsa or there's Hafsa. Okay, there's Hussein also. Okay, let's just say I am presenting Halima Ali. Let's say this patient is 2 years, female, his day post-admission is 1, informant is the mother. So let me just summarize this history. And the summary should be as short as possible. Make it easy for the consultant to understand. So I can say, I am presenting Halima Ali, a 2-year-old female, 1 day post-admission, whose informant was the mother, complaints of diarrhea, presents with diarrhea and fever for 1 day. The mother reports an onset of watery diarrhea 2 days ago, occurring approximately 8 times a day. The mother reports also a fever that started concurrently with the diarrhea, ranging between 38.5 to 39.8 degrees Celsius. There was watery diarrhea with fever, foul-smelling stools, decreased oral intake, and lethargy. However, there was no reported vomiting, abdominal pain, or respiratory symptoms. The patient is currently on oral rehydration therapy and is responding well to treatment. That's a good summary. But make sure you put it as short as you can, maybe in about 5 sentences. So you can see how this is an example I've put for you in the slides. You see how summary is done. Are you able to hear me clearly?
Yes, we can.
Okay. Yeah, thank you. So this is an example of a summary, and I showed you how to summarize. Now the general examination is also a part where people lose a lot of marks. People jump to jaundice, anemia, capillary. No. You do the general examination first in a systematic manner. Describe the general condition of the patient. Say, on examination, the patient was lying supine in bed, oriented, you can say the patient was on examination, the patient was lying supine in bed, oriented, with maybe anything that's on the patient, maybe with an oxygen mask in use, or maybe with an IV cannula in situ on the left arm. Was it in use or not in use? Was it just a blank? With IV cannula in situ, with an infusion of normal saline, with IV cannula in situ but not in use. Then describe the general nutritional status of the patient. Patient who appeared well nourished, etc. That's how you introduce the general examination. For the nutritional status, it's good to check the hair distribution. In kwashiorkor or other malnourished state, the hair starts falling off and becomes thin. So you check the hair distribution, check the mid-upper arm circumference. That's why you always need a MUAC tape. If you don't have a MUAC tape, it's good to carry a tape measure around with you. For the weight, refer to the booklet. And you comment, is it the patient malnourished? Does the patient look obese? Or is the patient well-nourished? The vital signs, you always check 5 vitals. If you can't find it, just ask a nurse who's going around. Those KMTC students that normally check the vitals. They always have the vital charts for those patients during clocking. Asubuhi wanakwanga wameshapiga hizo vitals. So talk to them, to give you the vitals. Check the pulse. Pulse, you don't need any machine. Put your 3 fingers on the radial artery. Check for the pulse. How many beats per minute? Is it a strong pulse or is it a weak, absent pulses? Mention the character of the pulse. The respirate, you don't need any machine. Check the respirate. And the pulse, ideally just take 15 seconds in exam situation, then multiply by 4. So you need to also have something like a stopwatch or a clock going on your phone to time these things. But ideally, if you're asked to do with the consultant, show me how to check pulse. Don't do the 15-second thing. Always do for 1 full minute. Then the body temperature, you can use a thermometer or get the vitals from the nurses. Blood pressure is important, and SpO2 is important, especially patients with respiratory. Are we clear there? Can you hear me?
Yes.
This is just a chart showing the respirate and the heart rate. You can always refer to. Maybe you can take a screenshot of it. It's very unfortunate. You cannot cram all this, but maybe you can just refer. Time exam tumejiandikia mahali tu nyuma. You just refer to that paper or wherever you've written and check, is the heart rate normal? Or is there bradycardia or tachycardia? Or is the respiratory normal? Is that or etc.? Always in your general exam, never fail to do anthropometry. You always do your mid-upper arm circumference in centimeters. You always check your weight from the booklet or from the mom, and you always get your height. So for children under 2 years, even if they're walking, we always take their height when they're lying flat. We use something called an infantometer. We always use an infantometer. So it has just put the baby on a wooden thing, and it's only the leg piece that moves. So we take the leg piece, and you make the head is on one end of the board, and it's board the leg moves. That's in the infantometer. Under 2 years, regardless of whether they're walking or not, always use the infantometer. But 2 years and above, we always use the stadiometer. Stadiometer, S-E-A-D-I-O, then meter. For the stadiometer, because the patient is standing, it's the one you find in walls in KNH. Patient, it's a calibrated wall, a calibrated equipment. Which piece will move? Are you going to move the ground to the baby? No. The head. Because you cannot move the concrete floor. So that's how you go about it. For the infantometer, it's the leg piece. For a stadiometer, it's the head piece. So the current weight and MUAC, I'm going to show you how to MUAC. And also the weight and height to get it from the use those infantometers. For the weight, we'll put on a Salter scale or any scale, measure the weight. If you don't get a chance, I know you won't get any weight or height, mother, the nurse, or from the booklet. So before you check the MUAC, ideally, you measure. This is about 0 centimeters. You measure from this point, from the tip of the acromion, the olecranon process of. Let's say you find it 16 centimeters. Then you mark with your pen the mid. So the middle will so just mark it. Then you come and fold this thing like this. I'll show you how it's folded. So it's folded such that this end goes around the baby's arm and comes here and now going out. Have you understood? So this end, you take it, once you've marked the mid upper arm, you take it, you put it under here, then it comes out in a cover. Yeah, you cover it and you fix it not too tight. Then you read that reading. If that reading falls in the green area, it's 16 centimeters, you say. It's like a belt. It's like a belt, this thing. The belt ties you tightly, you're thin and you're wasted. So if it falls on the yellow line, that is what we call the MAM, moderate acute malnutrition. If it falls on the red thing, that's severe acute malnutrition. Are we together? Can everyone hear me?
Yes, you can.
Okay, let's continue. Then now is when you come to this Jaclode. Many people have come across it. You just now come to jaundice. Don't worry, we're almost. I just didn't want to leave out any detail. Now is when you come to Jaclode, where for jaundice, you check for anemia or pallor. Make sure you check for central and peripheral pallor. Central means in the tongue, peripheral means in the fingers. Same with cyanosis. Checking for finger clubbing. Finger clubbing, you're going to tell them to bring the fingers together. You check for that window. It's called the Shamrock window. Is there a diamond tipped window? It should be there. Capillary refill. Where do we check the capillary refill? Where do we check the capillary refill? Is it at the finger, the nail? We always check the capillary refill here. We press the pulp of the finger. I hope you're able to see my screen, right?
Yes, you can see.
So we don't press the nail. We never press the nail not for capillary refill. Yeah. For capillary refill, we never press the nail. We always press the palp of the finger, count for about 3 seconds. Normally, they like saying Kenyatta 1, Kenyatta 2, Kenyatta 3. Then you leave it. Ideally, it should return in about 2 seconds, less than 2 seconds, 1 to 2 seconds. From 4 seconds, 3 is like midline. From 4, if it returns in 4-5 seconds, it's a delay. It means blood is not reaching there. It could be a sign of dehydration or shock. So why don't we press the nail also? Because, for example, you might find some girls put a lot of nail, or I don't know, Q-Tex or what, the nail thing and the nail. So it's very hard to see the cap refill from there. So ideally, you should always check the pulp of the thing. Let me go back to my presentation. We're almost done. So, so I'm told to repeat hapo kwa MUAC. I was breaking. Okay. For the MUAC tip, let me just repeat, but we're almost done. We're just 2 minutes, 3 minutes done. So for the MUAC tip, let me pointer. You measure first the mid-upper arm circumference, putting this at the tip of the acromion process of the shoulder, of the shoulder, I think. Then you put it up to the the 0 mark should be there on top of the shoulder. Then olecranal process of the elbow, that elbow prominence, you measure halfway, you get that mark with a pen. Then you put it like a belt. You roll it around, then it from behind. Comes, covers this.
Sadru, you're breaking again. I think he's having a network problem. Let us wait for him to rejoin, please.
Yes, Sophia, assalamu alaikum.
Alaikum salam, Sadru.
So I'm sorry, can you see my screen?
Yes, you can, Saddrudeen.
Sorry, I think the Wi-Fi just I think the lights just went, so I had to buy a bundled screen. So I think able to see my screen?
Yes,
Almost
it is.
finished.
Yes, you can see. You can see.
Okay. So you check for lymphadenopathy in the neck. Always never forget the axilla when you're checking for the lymph node. And you check for edema, pedal edema. How are you going to check it? You always press on the bony prominences. You check for any wasting. Maybe if there's the zygomatic bone is very prominent, or you can see lots of bones in this baby. Ideally, this baby is wasted. Also, it's good to check for hydration or the dehydration status. You can check for any signs of sunken eyes. You can check for skin pinch. You try to pinch the skin, and it should return as soon as the capillary refill, at least 1 to 2 seconds. So if it takes longer, it means there's less fluid in the skin. So you do a skin pinch. Also, you can check both hands at the same time, like shaking the hands from the fingers go up. Is the patient cold and clammy? If the patient is cold, it means there's low perfusion to the extremities, and it could be a sign of dehydration. So let me put a pointer. You can see in the presenting complaint in HPI, you already have, this is the marking scheme according to the PEDS department. It's 20 marks in HPI. The rest are 6 marks, 8 marks. You can see past medical is 6. ANC is quite important. Nutrition is important. Immunization is important. Growth is about 4 marks. Milestones is about 6 marks. Family social is quite important, 15 marks. And general examination, you can see, has the highest marks. So don't jump to the crowd. Introduce the patient lines fine, blah, blah, blah. Always remember to mention your vitals, then jump to the jaundice and everything. If you jump to jaundice, you won't get the 25. You'll barely get 10, maybe half. That's just a quick heads up. So for the general examination, mentioning the general condition, the jaundice, anemia, all of them are 2 marks. Cyanosis, finger clubbing. Remember the neck lymph nodes, and don't forget the axillary, because it's 2 marks. If you forget to palpate for the axillary lymph nodes, you're doomed. You've lost 2 marks already. Very easy marks. Pedal edema, remember you're pressing against the bony prominences. Then you're checking the hydration and the dehydration status. Then doing the MUAC, the weight, height, and the MUAC. That's why MUAC tape is essential. Please get it from your friends or buy it. Then the vital signs are important. So we'll just check a video. You'll just confirm if you're able to hear someone is asking, how do we get the vital equipment? Yeah, for the vitals, just ask the nurses. And if, let's say, you're in a situation where you don't get a nurse, you don't know the mother doesn't know what the vitals are, the baby's pressure for today, blood pressure or anything, or you can't get, there's no way, and there's no equipment, always also indicate in your history. For the vitals, for example, if you're presenting this, for the vitals, I'd like to do blood pressure, heart rate, but there was an availability of equipment. Just mention, don't skip it. Explain yourself, and you still get the full mark. So I think I sorted that question. So we'll check a video. I hope the sound will be. Let me see. So can you check if you're able to hear? Are you able to hear?
It's audible.
Are you able to hear? Yeah?
Yeah, it's audible.
Okay. We're almost finishing. So that's the lymph nodes, the technique. Stand on the back of the patient, the submental, the anterior auricular, posterior auricular.
Hello, my name is Dr. Gill. I've been
So
asked to
introduce yourself.
perform a general examination on yourself. Before we start,
Ask
please
for
confirm
consent.
your name and date of birth.
Yeah, my name is Megan Struthers and my date of birth is the 22nd of February 1998.
Super, thank you.
Sanitize, always sanitize.
So in terms of doing the
wear
examination
gloves.
today, that's going to involve having a look at your hands, having a look at your face, getting you to do some manoeuvres for me. We're also going to have a look at your chest. We're going to do your vital signs, and we'll also have a look at your legs. Is that okay?
Yeah.
Super. So to start off, if I can see your hands, please. Okay, so I can't see anything untoward there. If you could turn your hands over, please.
Start with their hands.
No obvious issues. To put their hands out straight.
Just ignore this
And
part.
we're checking for a initial tremor.
Ignore the tremor part.
And
Just
we'll
go with what I
pop the
talked
wrist
about.
back. So we're going to go on. I'm just going to take a pulse
Pulse
on both
is taking one of
sides.
the vitals. 3 fingers. Always use 3 fingers, not 2 or 1. For 15, then you multiply. But in exam station, if you're told to do, listen for a full minute. He's looking at the clock somewhere. Then he's also simultaneously observing her breathing, how her chest is rising and falling. And 15 seconds, then multiply by 4. Those are 2 vitals that machine he can do.
Super, so you've got a normal pulse there and also a normal respiratory rate. I'm just going to check your arm. Okay, and there's a normal pulse there as well. So I'm just going to have a look at your eyes if I might. So if you could look up.
What is he checking? He's checking for anemia. You
then
tell the
look
patient to
down.
look up, but jaundice, you have to pull up.
Super. Can you show me your
So I
teeth?
hope.
Okay, and show me your tongue.
So you can see for jaundice, you pull the sclera. If you pull the upper eyelids, then you maybe put your hands maybe on the patient's abdomen, and then Mwambie, look at this other hand. Ideally on the upper part of the eye, the sclera, it's called the upper part. You see the yellow deposition of this. That's how you check for jaundice. So we continue.
Okay, and put your tongue
Opaline
through your mouth,
cyanosis.
please. Super, that's fine. So I'm now just going to do your blood pressure. Do you have any problems with either of
It's
your
checking the
arms?
blood pressure. This is a manual blood pressure.
So we're going to do this twice. We're going to do it once without the stethoscope.
Also
and
learn
then once with.
to do a
So
manual
just checking the
blood pressure
size.
now. Also learn. I think you were taught in physiology, but nowadays they're the automatic ones. But it's good to
Artery.
learn a manual one.
And then coming around. Okay, and just relax for me.
So what mistake? Wait. Let's just continue.
So the pulse has disappeared. And the pulse returns to about 98. Okay, so we're just going to do that again with the stethoscope. Okay, you can relax the arm for me. Just putting that over the artery.
Don't worry, we're almost done. Just two more.
Okay, we're going to
Two
go a
more
little bit
minutes.
higher. And I can hear the sounds that get at 100. And they've disappeared at 68. So a normal blood pressure there, thank you. So
It's
just
checking
going
the
to check,
temperature.
your temperature at this point.
That's the fourth vital is checking.
We've got a normal temperature all in the green. And we're just going to check
He's
the
checking
oxygen
now the fifth
saturations at
vital,
this
which is
point.
the SpO2.
Would you have a finger for me? Thank you.
So you can see the SpO2 is here. It's 100. And you always check the waveform of the SpO2. Inafaa kuwa like regular waves. If you get something irregular or flat, you're not. It's contraindicated to check the SpO2. You have to wait for this wave to appear, or lines. You know, it can be bars or something to be regular. There's a regular pattern. Now you can read the SpO2. It's about. It should be at least 90 something. It can't be perfectly 100.
Okay, so we've got 99%.
It's 99,
sounds.
okay.
That's absolutely fantastic. Okay, if I could, you swing your legs forward and sit that way. I'm now going to put my hands on your neck, if that's okay, and we're going to see if we can find any lumps.
So it's checking for lymphadenopathy. You
Okay,
always
move
compare
your head
both at the
backwards,
same
please.
time. That's why you have to stand at the back of the
Starting
patient.
off under the chin.
So you have to stand at the back of the patient so that you're comparing the right and the left. So that when you feel a mass on the left, you can easily tell that the mass is not on the right, and probably it could be a neck swelling or lymphadenopathy.
And then in front. Behind.
The occipital, just know the lymph node, the anterior cervical chain,
Okay, and if you could shrug your shoulders up for me, please.
the
And
supraclavicular.
relax down.
It's checking.
That's all fine. So if you could lie back again on the bed for me. So just having a look at your chest, I can't see any.
So the mistake he did is what? On the lymphadenopathy? Anyone who knows? Looks like he's done with the lymphadenopathy. He forgot to check for the axilla. I understand it's because of the video, because the patient is female, but ideally you should never forget the axilla because you're losing 2 marks. So we continue.
Any obvious issues in terms of the skeletal appearance? So we're going to go down to your legs. I'm going to check for any problems.
So he's checking for edema.
Edema down here, any swelling?
On bony prominence.
So pressing
Press.
on both sides.
I remember in my pediatric exam in third year, end of rotation, I was told check for edema. And I told the consultant, edema, I'm going to check by looking at the lower limbs and pressing against the bony prominence. That's what I told him with mouth, but I never did it. That's how I lost the marks. Aliniambia, after you don't say it with your mouth. You say it as you're doing the action. You're describing, but you're doing the action. Always do.
And there's nothing there. And then the pulse is behind. Good. And we've got normal pulses there. So I couldn't find any abnormalities on that general examination. Do you have any questions for myself?
No.
Super. Thank you very much for your time.
So it's over. Any person with any question, I think I try to. So for the ear, for the temperature, because it shows like the core body temperature, it's not like the one on the skin. It's more accurate. The ear one, the one that you put in your mouth, those probes are quite accurate, more than the ones you do. Remember the one in COVID, where you do, it's about maybe 1 degree lower than what, because of loss of heat. You have to make the best thermometers that make contact with your body. Maybe in the armpit, mouth, when you interact. Yeah, the core temperatures. So MOAC tape ideally you should do, and let me just give you a good tip, especially for the young patients. Don't change the setting of the patient. You can do I know someone is asking the best position. If you have to change the patient position, you go to the back of the patient, just mwambie patient akae na kando, then you make sure you're behind the patient when you're doing the lymphadenopathy or examining the lymph nodes. Or if you can't, just put your, I think, left or right arm longer and make sure, as long as you check both at the same time. MOAC, you can do it any position. But one tip I can give you, for the young patients who you cannot separate from the mother, it's not ideally good to separate. You can do your general examination while on the mother's lap. That's a good tip I'm giving you. Always do it on the mother's lap if necessary. It's when you only change the setting in an emergency situation. The baby is not breathing, you're allowed to take it from the mother. But everything, history, everything, make sure the baby is on the mother's lap, because the baby will be more comfortable. You don't want a crying baby when you're doing the general examination. The vitals will be off. The blood pressure will be high, the temperature will be high, the respiratory will be high. You don't want that. I don't think there's any other question. I think I covered it in detail. Yeah. Any comment or question before I leave now?
Saddrudeen, before you left, I think there was questions in the chat box.
Yeah, I'm going actually. I'll
No, no,
present.
before you left the meeting.
Oh, okay. Can you read them for me?
Yes, sure. So, Salma was asking, how many hours do we consider as a prolonged labor?
I think about 3 hours for a primigravida or maybe a new mother. I'm not sure, but just check this information. Or about 2 hours when labor starts, the first labor starts, the contraction start, and the baby takes, for a mother who has experience in labor, maybe has multipara, a mother with maybe previous deliveries, it's more than 2 hours, but 3 hours for a primigravida. Remember, the new mothers, they need to learn the technique of how to push and everything, so it takes longer. So they give it an allowance up to 3 hours.
Yes, to just add that with what Saddru said, and the definition, if you look at it, is just anything that's lasting more than 24 hours. That's a prolonged labor. But then now, the prolonged labor initially has 4 stages. You have the first stage, second stage, third stage, and fourth stage. So second stage, a prolonged labor for primigravida, it's more than 2 hours. And for multipara, it's more than 1 hour. So yeah. Second question, it's complication related to preterm and postterm.
Preterm and postterm, okay. So for preterm labor, actually postterm is not quite common unless the mother comes from a very remote area. Postterm is very rare to see in Kenyatta. Preterm labor is any or preterm delivery is any baby that comes before 37 completed weeks. So the complication with this is, the baby is not yet fully developed actually in the lungs, the surfactant take about, they start being produced at about 24 weeks. Then they mature up to 34 to 37 weeks. And at 37 weeks, fully completed weeks, is when the surfactant is mature and, the baby can breathe without any help. So for the premature babies, the risk factors is, first of all, their bodies are very weak. They have a small size, and I think we were told in biology, surface area to volume ratio. They can lose a lot of fluids through the skin. They need a lot of fluid and feeding requirements because of the larger surface area to volume ratio compared to a full-term baby. They're also predisposed to infections. Remember, they're not ready to come out of the uterine environment. They still need time to develop. And also, there is also risk of something called RDS, which is respiratory distress syndrome. That's very high yield in pediatrics. If you learn pediatrics in 5th year, lazima ujue respiratory, because it comes as a result of inadequate levels of mature surfactant. So for preterm labor, and it's inevitable, the cervix has dilated and the baby is coming out. Sometimes they try to give the mother injection of dexamethasone, which is steroids, to ensure those dexamethasones, at least if you give it 24 hours before birth, and this birth is coming and it's inevitable and it's a preterm birth, it ensures there is adequate levels of, it triggers the maturation of the surfactant. Another complication is they can be exposed to jaundice, leading to kernicterus and, severe brain damage when there is insoluble bilirubin being deposited in the basal ganglia, leading to kernicterus, which has very severe complications in the baby. Why jaundice? Because once they come out, remember their liver cells are immature, and they normally have a physiologic destruction of. Remember, in the hypoxic environment, the baby's normal hemoglobin ranges between maybe 13, 12 to around 16, 18. But in a baby, because of the hypoxic environment, high levels of HbF, the hemoglobin is normally about 21, 25 there. So when they come out, there has to be a hemolytic physiologic anemia, where now there is destruction of these red blood cells. And then you find that the liver, if you check the pathology, the pathway, you have hemolysis or destruction of red blood cells by the body. The liver has to be involved to conjugate now this, when you have massive hemolysis, there's conjugation of unconjugated bilirubin. Now the liver enzymes are immature for these babies. So you find lots of unconjugated bilirubin flying around. That's why they get deposited in the skin, in the eyes, leading to jaundice, and also in the brain, leading to panic. Those are the complications of preterm. Post-term, mostly, the baby can grow larger. The baby is continuing to grow. They normally grow at a very fast rate. They might grow such that they cannot come out of the mother's womb, leading to cephalopelvic disproportion, leading to unnecessary cesarean section. And it can also lead to intrauterine fetal demise, because the baby is growing, but the space is minimal. So ideally, the best time for the baby to come out is between 37 completed weeks to 42 weeks. I think that covered it. Any other question? Finger clubbing, I know it's kind of hard, but just ignore it. I'll just put there for not. Remember, pediatrics, you won't find only babies. You will find also babies up to 10 years. I don't call them babies, maybe not adolescents up to 13 years in the ward with meningitis, with anything. So they also good to check finger clubbing, especially in the older babies. Good question. Salma is saying, if the patient had recurrent infections since 4 months and had a past. Okay. You can just describe HPI. No, for the it depends. If it's the mother having the infection, the recurrent infection, Salma, you put this in the ANC history, not in the HPI. HPI, maybe if it's the baby who has severe pneumonia, describe the baby symptoms. All the baby symptoms, HPI. Don't put about history of recurrent infections during birth. Salma, can you ask a question? I didn't understand.
Sadro, I was asking, in case like the patient alikuwa na recurrent infection since 4 months, she's been off and on and off for Hosi. But Sasa, there was a case, she told me she had a TB in previous admission and it was resolved. They took care of it and Sahia Kosa. Now they are just brought for the
Yeah,
other pneumonic symptoms.
okay. That's, you can mention it in the HPI extensively, but then when you're doing your past medical history, just say the patient had known TB for since 4 months that was treated. The consultant will understand that you brought it in the HPI because it might be relevant to the patient because the patient was presenting with pneumonia now.
So
Put it
where,
in
which part of HPI? Like at the beginning, I'm Komusho. After I've exhausted the symptoms.
Just put it at the end.
Okay.
Because I don't want you to put it in the front as part of chronic illness, because it will deviate the consultant. I want you to focus first of all. You know, the consultant in the HPI just wants to listen to you, how the way you're describing the symptom.
Yeah.
I think you put it just at the end. So just mention it in detail.
Okay.
Or you can leave it, mention it in detail in the past medical history, which is the better option. And you say the drugs that they were used. Did they complete TB treatment? Ideally, I don't know, it's about 3 months or 6 months.
6 months. Okay.
Yeah. I think there's no other question. Anyway, I think I did this.
I think that's it. Just before you leave, Sadru,
Yeah. Okay.
I just want to take this moment to express our heartfelt gratitude and thanks for taking us through this session. Najua, as I am sound, hauna time. You have to
actually say nataka nikimbie KU kwa our conference.
Exactly. So thank you for your time and effort, inshallah.
Okay, you're welcome, inshallah. If there's any, I think I'll share with you mostly the presentation.
Okay,
Then
I'll share
you
with the
can
group.
share it with the rest. And also the recording, maybe for those who miss.
Okay. That's okay.
Yeah.
Sure.
Thank you.
Yeah, you're welcome.
And mashallah, you guys are very lucky. Mnapitisha hizi sisi tulikuja kusoma history very well in 5th year. In 3rd year it was just joyriding. But you're very lucky. Say when you do the exams, you'll be at a very good advantage. You're all welcome. Thank you. I think now Sophia and her take over for obscuring. Yeah. And sorry for taking a lot of time and breaking at the in between.
It's okay.
It's not my hi.
It's okay. Thank you, Cedric. Thank you very much. We appreciate it.
You're welcome.
Okay, bye guys.
Sophie, you make sure you record your session. Mustafa, make sure you record your session. I'm in obscuring rotation now. I would like to listen to this recording because it's
okay,
can really benefit a lot. Inshallah. Yes, shukran.
Ma'asalam, guys. Bye.
Are they coming back? I think ma'asalam, are they coming back at what time?
Another session.
I don't know if I think Sophia is also presenting.
Oh, okay.
About obsgain, I think. Just confirm with her. And then Musti, if you're free, you can record. If you're not,